Hi, I'm Kristen here at UT Southwestern Medical Center. Thank you for tuning in to our second of 3 Facebook Live chats as part of Stroke Awareness Month. Today we're going to be chatting with vascular surgeon Melissa Kirkwood about how some vascular conditions can lead to stroke as well as some potential treatments. So Dr. Kirkwood came to UT Southwestern in 2011 and now leads our vascular surgery vein clinic. So now before we get started, don't forget, make sure that you like and love and share our conversation along the way with your friends and followers. And don't forget to ask questions in the comments field. So we will take as many as we can get. So to get started, I want to thank Dr. Kirkwood for being here.
Thank you, it's an honor.
Yeah, it should be a lot of fun. So let's start out with just a really basic question about, since you are a vascular surgeon, I mean, what is stroke?
So, stroke is the third leading cause of death in the United States. And there's 2 types of stroke, either hemorrhagic or ischemic. 85% of those strokes are ischemic, which means decreased blood flow to the brain for one of several reasons. And that can cause debilitating consequences. About 15% of people who have a stroke die in that same year. And up to 15 to 30% of those patients are, chronically disabled from the stroke. So our goal here at UT Southwestern is to prevent stroke, obviously.
Mm-hmm.
But also once stroke signs happen, we want to deal with them quickly and efficiently. Mm-hmm. And so as vascular surgeons, we're mostly involved when strokes come from carotid disease. So the carotid arteries are the main blood flow to your brain, and they're a very common source of plaque buildup, atherosclerosis, calcium, cholesterol. And when that builds up, sometimes that plaque can flick off at the bifurcation and go up and cause a stroke.
Okay.
And we like to intervene early by doing surgery on those patients that are appropriate and removing that plaque and trying to restore them to their good quality of health.
Which brings up a really good question. And this is something that we were asked last week and that we keep getting asked. I mean, what are some common risk factors for stroke?
So the most important risk factor is smoking. Smoking cessation significantly increases your risk. If you are a 1-pack-a-day smoker, you have over 2.5 times the risk of stroke than someone else in the general population who's a non-smoker. Wow. So that's one thing we always want to work with here in terms of prevention, is really trying to increase smoking cessation. Other risk factors are things like diabetes, high blood pressure, and all the different atherosclerotic factors. People with a history of heart disease are more likely to have carotid disease and are at increased risk of stroke. So those are the main ones.
Well, I know that we've seen, or some people, they remember that, a stroke happens in your brain. I think they forget that, it's actually you have a stroke because something is clogged in your body and the blood isn't getting to your brain.
That's correct.
So, I mean, what do you do as a vascular surgeon, both to prevent strokes and then to treat them?
So, we as vascular surgeons also do a fair bit of medicine, and we follow our patients chronically. Once you're a vascular patient, you're always a vascular patient. So we follow patients who have known carotid blockages, and we surveil them with ultrasound, and we see them every 6 months to a year in our clinic to make sure that there's no new symptoms of stroke, and also to make sure that their plaque has not progressed.
Okay.
And once it progresses to a certain level or they start having symptoms of stroke, we intervene at that time by doing surgery and removing the plaque.
Okay.
And after that, we continue to follow to make sure that there's no, problems in the future. So it's kind of a lifelong commitment from our vascular team to the patient, and also we help lower your risk factors as well.
So with that in mind, do you always have to do surgery? Are there other options that people should do or consider?
There are, and so surgery is only for a percentage of patients, because a lot of strokes actually are not from carotid disease. They could be from other problems, blood clots in the heart, and bleeds in the brain, and other various causes. But it's our job here at UT as a collaborative group in our stroke center to kind of flesh out what's going on and be able to address any issue, and I think we do a good job of that here. So we do recommend surgery when the stroke is related to carotid disease, and we do less invasive techniques here. We also do carotid stenting. I would say that the majority of patients should have the open surgery as opposed to carotid stenting. Carotid stenting has been shown in some trials to have a slightly higher risk of stroke. but it is definitely a great option for some people who can't tolerate open surgery, perhaps because of other comorbidities, heart problems, lung problems. So we offer both options here.
Okay. Well, we've got a question in from a Deborah. Deborah is wondering, is the high heat alone a stroke threat while walking long distances in summer to older adults?
So it's always important to stay hydrated and stay cool, especially in these heated months in Dallas and especially in the elderly. It's not so much related to an ischemic embolic risk, meaning carotid disease and plaque flicking off and causing, but it definitely can be a cause of passing out or low blood flow, low blood pressure, which could cause kind of a global ischemic event to the brain. So it's definitely important to always stay hydrated and try and stay cool in these summer months.
Okay, that's a good question, Deborah. Thank you. So what can somebody do to prevent stroke? Are there any things they can take? I think I read somewhere that walking was good. Not quite sure what that would be good for.
Yeah. Well, anything that does risk modification is good to prevent strokes. So exercise, always good. Eating healthy, always good. You know, once you become a vascular patient and you have evidence of plaque, we often recommend cholesterol control with a statin agent or medication, as well as aspirin therapy. Vascular patients are often on aspirin therapy. So also getting blood pressure under control and tight sugar control for our diabetic patients are key in terms of minimizing the risk to decrease the risk of stroke.
Okay, so how does the sugar play a role into that? I know that when we were speaking last week with Dr. Welch, he said that diabetes could be a contributing factor. How do you see that?
Well, I think that, you know, poorly controlled diabetes can be just a marker of other problems as well, and it can cause problems with the kidneys, other problems with the heart, and so it's best to really maintain normal blood sugars.
Okay, so one of the we talked a little bit earlier about kind of those minimally invasive procedures. Now you said that they're not an option for everybody, but if you are a candidate for one, like, what are they, and are they as effective as minimally invasive?
Yes, so carotid stenting is the minimally invasive procedure compared to carotid endarterectomy, which would be the open surgery, and there are definite benefits to both. I do think that right now carotid stenting is mostly for patients who wouldn't tolerate open surgery, so perhaps someone with poor cardiac function, a bad heart, or maybe someone on oxygen from poor lung function. And the stent, the bonus of that is that you're awake the whole time. You know, we're doing it under direct neuromonitoring by kind of talking to the patient and making sure nothing's going on. Whereas carotid endarterectomy does require usually the patient to go to sleep, but they both have about the same length of stay, usually 24 to 48 hours.
Wow.
And both patients typically do very well. So it's a discussion between myself or my partners and the patient, as well as, you know, what the patient wants to do. And, you know, we lay out the risks and things like that, but we tend to offer open surgery to the average risk patient. My bias would be that perhaps it's more, you know, a better long-term solution. Okay. But we do surveil the stents afterwards as well.
So one of the questions that came in before this was somebody was wondering, you know, we talk about minimally invasive and open. When you're talking about vascular surgery, what does that mean? I mean, because minimally invasive can be like a small incision, but we're talking about going into our arteries and our veins. How does that?
So for a carotid stent, for example, there really is no incision. So we do it all through a catheter in the artery from the groin. And we're able to cannulate the artery in the neck to the brain, and we're able to place a what we call a distal embolic protection device, which catches all the plaque that might be dislodged when we deploy the stent. And then we open the blocked artery with a stent. So that is minimally invasive in the sense that there's no incision. The carotid endarterectomy is an open surgery, but even so, for vascular terms, it's relatively minor invasive because the incision is about this long right here in the neck. Wow. So it's not quite as invasive as perhaps some other vascular problems that we deal with.
Okay, awesome. Well, thank you all for asking questions and continue to like and share our conversation. Please continue to do so. We've got about 15 minutes where we can take more questions, so keep them coming and continue to like and share the conversation. So So while we're moving forward, I mean, we talked just then about minimally invasive procedures and are they effective? I mean, what's on the horizon for new therapies? Is there anything coming out that people should ask about, or that they should do some research on, that they should contact you about?
Well, we're always at the cutting edge here at UT Southwestern, definitely for all areas of vascular care. In terms of stroke prevention, I think the most important thing that patients can do is just be aware of the risk factors and know how to prevent strokes, and also recognize the signs and symptoms of stroke. Because often we see patients days to weeks after an event when they didn't perhaps give it attention. And I think it's important to kind of be aware of perhaps stroke-like symptoms so that we can, treat you efficiently and effectively.
Gotcha. So Teresa is wondering, she says, do you think bicycling is good to support vascular health?
Yes.
And why? I know she's a hardcore cyclist around here.
Yes. And any kind of exercise is great. Whatever you can do, bicycling, just even walking, rowing if you're into that. Any kind of weightlifting, anything is good. But even just generic walking is good for cardiovascular health. So the more you do, the better. That
sounds great. So we've got something from John. He says, Dr. Kirkwood, I have enjoyed following your work over the years. Thank you for speaking today. He says, today's discussion is important. How do you approach the asymptomatic patient with carotid stenosis?
That's a great question. So, there's been a lot of research in terms of when do we offer surgery and which patients, because we ultimately want to offer the best outcome for every patient. And so we often find patients who have a carotid blockage that was found incidentally. They don't have symptoms of stroke. And then it becomes a discussion and a risk-benefit ratio in terms of who would benefit from surgery. What we know from the data and kind of the general practice of most vascular surgeons is that if it's asymptomatic, which means no stroke-like symptoms, that if it's greater than 70 to 80%, we begin to talk about surgery. Because what we know is that we can decrease your stroke risk from about a 5-year 11% stroke risk to about a 5% stroke risk with surgery.
Wow.
So
it's a big drop.
Yeah, it's about 50. Yeah, it's a 50% drop. So we can mitigate some of that by doing the surgery before you have symptoms. So that's why it's important always, and we love the help of our primary care partners, because they often are screening your carotids by listening with their stethoscope on the carotid to see if there's any kind of turbulent flow that would suggest that perhaps there was a blood flow problem. And then we like to see you in clinic to do a formal ultrasound and just make sure, so that we can follow you appropriately and intervene when necessary to prevent stroke.
Gotcha. All right, so we've got one from Susanna. She's wondering, are risk factors for TIA and stroke the same?
Yes. So a TIA, or a transient ischemic attack, is basically a mini stroke. It's a stroke where symptoms resolve within 24 hours. Okay. So it's the same exact event, but if you're lucky enough to have your symptoms resolve, it's considered a TIA. And if your symptoms persist, then it's considered a stroke. And it's the same risk factors: hypertension, diabetes, smoking, cholesterol, plaque, family history, things like that. But we want to always kind of intervene. We want to see that patient in the ER, when they're having that TIA, because then we're well equipped to kind of handle whether or not it's going to progress or not.
So with the TIA, should people take basically the same quick response they do with a stroke?
Yes.
Just go immediately, don't get your friend to drive you, call 911.
Right. All too often we see patients who perhaps had an event where all of a sudden their arm went numb, or they had weakness, or they had slurred speech, or even the family noticed slurred speech that then resolved. And patients often attribute it to, it was hot that day, or I hadn't eaten lunch, or I didn't feel well, and things. And we would like to see those patients here in the ER, because sometimes it is just that you didn't have lunch or that it's hot outside, but oftentimes it can be a warning sign of a perhaps larger stroke that could be impending. And so we do want to take those concerns seriously.
All right, so we've got one from, lots of people are saying great topics and answers. Kenzie is wondering, who is most at risk? Is it grandparents or young adults?
So less likely young adults, unless you have a genetic or family history of high cholesterol, and you've been struggling kind of with high cholesterol and hyperlipidemia and hypertension for years. Usually we tend to see it in patients, I would say, over the age of 60 or 65.
Is that primarily due to just the years? Maybe they've had more time for things to
right,
build up,
more time for
plaques.
More plaque to build up,
Okay.
exactly, more time for high blood pressure to start seeing the effects of all these kind of end stage problems. We typically, it's more common in men than women, but I do take care of a fair amount of women with carotid disease as well. So, yeah.
We talked about that a little bit earlier.
Yeah.
So we got another question from Kenzie. She's wondering, are the symptoms of ischemic stroke, hemorrhagic stroke, and TIA the same?
Yes, the symptoms are going to be the same, because what you're going to notice as a patient is some kind of neurologic change. Either a word-finding difficulty or weakness, numbness, inability to move an arm or a leg. Maybe sometimes we see it in elderly patients that get up and they fall when they normally don't fall, and they're normally steady on their feet. Or, some kind of focal neurologic deficit. And that can be a sign of any kind of stroke. And that's why you need to come in and get the appropriate imaging and see the different specialists so that we can help sort out exactly why this occurred. And obviously we want to preserve as much brain function as possible. So we want to kind of get on that immediately.
Right, so it seems like it sounds like from all the questions that we have a number of people on our stroke care team here. I mean, why should people come to UT Southwestern if they have a stroke, or if they think they have a stroke?
Yeah, so I think UT Southwestern is really a great place to be for a lot of big problems. We're a tertiary referral center, and we handle a lot of very complex patients transferred from surrounding states as well as within our city as well. And so you have a very comprehensive team. We're very collaborative here. There's a lot of great communication between all services to help take care of patients. And I think that's a great benefit to the patient, because we're able to tackle any problem that might come up. There's a specialist here to handle anything, and so I think that it's a great place to be for almost any problem. That's why I'm here.
So this question, I'm not sure you can answer this, but maybe you can. They're wondering, Sarah's wondering, what does rehab look like for stroke patients? Is that something that you interact with?
Yeah, we do, in the sense that we always want our patients to feel comfortable when they go home. So if they've had a deficit, occur, then our case management and social worker work with you and your family, trying to find a great place for rehab to get you back on your feet and moving again. And there's a lot of great places that we work with, and they focus on whatever the deficit is, whether it be a voice, a vocal problem, a phonation versus motor or sensory deficit. So, yeah.
Awesome. So let's see, another one of these questions that came through before. They're wondering about, apparently I think it's kind of unclear. I think they're having an angiogram coming up, and they're wondering what that means.
Okay, so a lot of places still do carotid angiogram for diagnosis of carotid stenosis. I would say we've gotten away from that because here at UT Southwestern, our CT scans are just so advanced. We're able to do a lot of three-dimensional imaging and software reconfigurations. So we don't typically need a carotid angiogram prior to any type of carotid intervention. We are able to combine, we usually do two-study modality testing, so we'll do an ultrasound in the clinic that will diagnose that there's a blockage. And then if it's concerning enough, or if the patient's symptomatic, we often then go to a CT angiogram with contrast, and can kind of get a clinical picture and an operative plan from that information. Some places are still doing carotid catheter-based angiogram, where they go in from the groin and go up into the carotid and shoot dye to diagnose carotid stenosis. Now, that can be coupled with carotid stenting. If you know there's plaque there, then you could potentially do that stent in that same procedure. But you want to make sure that you're not a candidate for carotid endarterectomy first.
Gotcha. So what is the when somebody comes in, and this is kind of a combination of things we received beforehand, when you're coming in to see a vascular surgeon, what should you expect?
So when you come in to see us, you might want to expect to have a study, because we work very closely with our vascular lab. We have excellent techs here at UT Southwestern and a fabulous clinic staff, so you'll get to meet them. But also it's important to get that test so that we can kind of be able to talk to you about what's going on and things like that. We'll also want you to bring your imaging. So if you've had imaging elsewhere, we would love to see it so that we don't have to be redundant or redo anything that's already been done. So we'll ask for your imaging, and then you'll get a one-on-one conversation with me or one of my partners about your risk and risk modification and different options going forward.
Right. So is there a way that you handle, I mean, how do you address those patients who maybe don't want to do what you recommend, but you're worried about preventing stroke or some other issue that might come along?
Yeah. So, I think that's a great question, because I think one of the things that comes up with our patients most is smoking cessation, really trying to get our patients to quit smoking. And, you have to want to do it on your own, I think, but I think that having a good commitment from your physician and a good relationship with your providers, and spending that extra time with them to ensure that we've really, discussed the risks, I think often that is what drives home the point and makes a more successful outcome.
Gotcha. So, John, thank you for another question, John. He appreciates your earlier response, but he's wondering, are there circumstances where you might consider performing carotid surgery in addition to another procedure?
That comes up, that's a very good question. That comes up occasionally when there's a patient who has two main problems. Perhaps someone has carotid plaque and they might be having TIAs or stroke-like symptoms, and they're also having chest pain and they need to have a CABG procedure or a coronary bypass.
Okay.
Then, if you need that kind of work, it's really important to be at a place like UT Southwestern, because we really kind of go over each issue and think about it, and sometimes we have to combine those procedures because, we don't want the patient to have a heart problem when we're doing the carotid. You don't want the patient to have a carotid problem when you're doing the heart. And so we often combine teams and work together and can sometimes do procedures in one setting. So that's obviously high risk, and we try to avoid that. But, we always ultimately have to do what's best for the patient. Sometimes that's what we need to do.
So let's talk a little bit about the carotid surgery that we do here. I know that's a specialization of yours. That's something you're really passionate about. What do we offer here that maybe somebody wouldn't find elsewhere?
So I think what we offer here mostly is we're very comfortable handling very high-risk patients.
Okay.
So we're very comfortable, all our procedures here at UT in vascular arena are performed with cardiac anesthesiologists. So anesthesiologists who are extra boarded in cardiac. And we have a whole floor to ourselves between us, cardiology and cardiac surgery. So it's a really great community, kind of a vascular kind of institute in among itself. And so I think that we're really equipped to handle anything that could be thrown at us. And I think that's one of the benefits of being in a tertiary care center, a big referral center. You've got a lot of minds thinking, a lot of minds working together for the best outcome of the patient. So, and we're a high volume center. So that's also, obviously, you want to go to a place that's a high volume center.
Absolutely. So what message would you leave for people that are watching or that are going to watch later about stroke prevention? What do you think people should really remember?
So I think you should remember, stop smoking. Always make sure your blood pressure is controlled, and follow through with your screening exams. If you know you have carotid plaque, make sure you come and see us, and we stay up on our surveillance to have the best outcome.
So how often is that?
So it depends. If you have a blockage that's getting close, so when you don't have symptoms like I mentioned before, we don't really operate till you get to be about 70 or 80% blocked. Okay.
Wow.
But we start following you more closely about every 6 months if you get above the 50% blocked threshold. Okay. So that's when we want to kind of see you every 6 months. Obviously, when you're symptomatic, we want to see you right away, and take care of that problem within the next few days. Absolutely. So usually our carotid patients we're seeing every 6 months, sometime every year if they've been very stable for a long time.
Wow. So if somebody, since our audience kind of expands beyond the Metroplex, if somebody is not within driving distance of UT Southwestern, what should they look for if they know that they have some kind of a vascular condition?
So, they should look for, as we discussed, any concerning signs, neurologic symptoms, changes. If you have a strong family history, that might be a reason to get checked out. Make sure, your primary care doctor is listening to your neck arteries and seeing if there's anything out of the ordinary there. So just kind of staying on top of your health.
Awesome.
Yeah.
All right, so one more question.
Yeah.
What are the main symptoms of stroke? What should people look for?
So that's great. So One thing we describe is transient monocular blindness. Patients often describe it as just a shade coming down over one eye. It just goes dark for a few moments and then it's back. So people often think nothing of it, but that is actually a mini stroke, and that's something that we would want to see you about right away. Other things could be transient, your arm, you can't move your arm, or you can't feel your arm. I have patients who say, I was fine, and then all of a sudden I dropped my coffee cup, and it took a minute for me to be able to pick it up, and then they're back to normal, things like that. A lot of times, as I mentioned before, you have family members that say, you are slurring your words just now. What are you saying? Yet the patient might be unaware of the fact that now they're slurring words, or that their face is a little hemiplegic. So, anything out of the ordinary, it's always better to come in and get checked in, get a non-contrast head CT, just make sure everything's okay and get the appropriate evaluation.
Wonderful. Well, I think we are running out of time. If there are any last minute questions, we can certainly take them. But otherwise, I really thank you for coming on, Dr.
Thank you.
Kirkwood.
Thanks so much. Appreciate it.
It's been a really great conversation. Thank you all for all of the questions that you contributed. We are going to be back next Friday. We're going to be in the PM&R gym talking about stroke rehabilitation at 1 p.m. So tune in next Friday. And again, thank you for all the questions.
Thank you.